Hi, I'm Hayley Chidlow and I'm an equine medicine specialist at Newmarket Equine Hospital, and I'm here today to discuss equine gastric ulceration as part of this module for Bimeda. I graduated from Liverpool University in 2011, subsequently spent some time in equine practice before completing an internship at Haggard Equine Medical Institute in Kentucky and a medicine residency at University of Georgia in the USA. NEH is a large independent equine referral hospital with a multidisciplinary team including multiple equine surgeons, medicine specialists and sports medicine and rehabilitation specialists. The hospital has over 80 stables, including a dedicated intensive care unit and separate isolation unit. Facilities include 2 operating theatres and 4 induction and recovery boxes, an imaging suite including bone scan and MRI, and multiple areas for trotting up horses, including a full-size arena and 2 areas to lunge horses. Today we're going to discuss equine gastric ulceration as part of this module for Bimeda. We'll be covering firstly an overview of gastric ulceration in horses, including looking at the prevalence, risk factors and the grading of ulcers. We'll then move on to some of the clinical signs that we might see, followed by looking at the diagnosis using gastroscopy. We'll then move on to looking at the treatment of gastric ulcers in horses and the prevention and management of this condition. We'll now move on to looking at the disease overview to start. So before we get started, I wanted to go over a refresher of the anatomy of the stomach. So horses are monogastric and there's 4 main regions that comprise the stomach. So the dorsal fundus, ventral fundus, cardia and pylorus. Dorsally, the stomach is lined by the squamous mucosa and ventrally by the glandular mucosa. And this mucosal lining is divided by the margo plicatus. The squamous mucosa is a pale pink to yellow or white mucosa, and the main thing about this is it has no absorptive or secretory capacity, so its function is as a basic protective layer. It lacks any form of mucus or bicarbonate layer to protect against acid exposure. In comparison, so the ventral glandular mucosa, this is a dark pink mucosa, and its primary function is secretion of hydrochloric acid. So it's comprised of mucus producing cells and gastrin glands, and then the hydrochloric acid is secreted in response to gastrin. The glandular mucosa, unlike the squamous, has protective factors to prevent mucosal damage. So an overview of equine gastric ulcers. So historically or previously, the term equine gastric ulcer syndrome was used to describe all equine gastric ulcers. However, we now understand that based on the affected anatomical region, so the squamous dorsal part of the stomach or the ventral glandular part of the stomach, these 2 locations can have very different prevalence, pathogenesis and treatment required for these types of ulceration. So therefore we now use equine gastric ulcer syndrome or EGUS as an overall general terminology for erosive and ulcerative diseases of the stomach. And this has now been expanded to describe equine squamous gastric disease and equine glandular gastric disease to describe ulcers based on their anatomical location. So we can see here in this picture, this is the inside of the stomach on gastroscopy, and we can see our pale pink squamous mucosa and our dark pink glandular mucosa separated by the margo plicatus. We'll start with equine squamous gastric disease. So this is what we've all tended to think of as our classic gastric ulcers. So this is by far the more understood form of gastric ulceration in horses. The basic pathogenesis of this disease is sustained exposure of the squamous mucosa to acid. So this can be either primary or secondary equine squamous gastric disease. So primary disease occurs in response to acid exposure that occurs usually as a result of the inherent risk factors associated with modern intensive management of horses that results in acid exposure in horses that have otherwise normal gastrointestinal tracts. In comparison, secondary equine squamous gastric disease occurs as a consequence of delayed gastric emptying. So this causes chronic gastric distension and prolonged gastric emptying. The characteristic lesions of equine squamous gastric disease are hyperkeratosis, erosion, and ulceration. So hyperkeratosis is the thickening of the keratized layers of squamous epithelium, and this results in a corrugated yellow appearance to the squamous mucosa. And this is likely a direct result of acid exposure, but it may be either an early manifestation of ESGD, or it could potentially be a response to healing. So we can see it both in those cases that we think are early cases of ESGD, and in those cases that perhaps have been on treatment and we associate it with healing of previous more severe gastric ulcers. Erosions are superficial damage to the squamous mucosa, and these can be focal or diffuse and appear as generally smooth, sort of red-pink lesions on the squamous mucosa. And then ulceration is where we have deeper damage to the squamous mucosa, so extending beyond the lamina propria, and you have complete epithelial loss. Now, in terms of location of squamous ulcers, the most common site is adjacent and just above the margo plicatus along the squamous mucosa. And while both the lesser and greater curvature of the stomach can be affected, the lesser curvature tends to have more severe ulceration when it is affected. Looking at the prevalence of ESGD, so generally ESGD prevalence is highest in performance horses. So this reflects the changes in the management and intensity of exercise that these horses have. We know that exposure to a combination of high starch diet, stall confinement and strenuous exercise can induce gastric ulcers, and these high performance horses tend to have a combination of all of these risk factors. And so depending on the study you look at, the percentages will vary, but as you can see, the prevalence in racehorses in training is very high, 80 to 100%. But when these horses back out of training, the percentage drops down to probably in the 30% region. So that's a much improved and again reflective of their management changes and exercise intensity. Likewise, sport horses, endurance horses can also have a fairly high percentage of horses affected with gastric ulceration. And the same with pleasure horses, even if they aren't doing what we would consider high intensity work, the management of these horses can also result in a high prevalence of gastric ulceration. And looking at the risk factors, as I've just discussed, primarily we're looking at intensity of duration of exercise and then their management factors. So it has been shown that the risk of ESGD increases with an increase in the intensity and duration of exercise. We know that strenuous exercise results in increased abdominal pressure due to contraction of the abdominal muscles, and this causes gastric compression and increases the exposure of the squamous mucosa to acidic gastric content. Strenuous exercise also causes an increase in the postprandial gastrin secretion, so you get an increased production of hydrochloric acid. And then looking at diet as a risk factor. So low roughage and high starch diets are known to be a risk factor. Basically, probably the main thing we're looking at is the time between our forage meals. So in horses where they're only getting minimal roughage, there's likely to be an increased time between forage meals, and this disrupts the normal pH stratification of the gastric content. So it allows high concentrations of hydrochloric acid and bile to mix in the dorsal stomach, as opposed to being trapped beneath the fibrous mat formed by roughage in the diet. Decreased roughage also results in less chewing, which results in decreased saliva production and less buffering of stomach acid. High starch diets can also stimulate the secretion of gastrin, resulting in further acid secretion. And then intermittent access to water is also a risk factor. In terms of turnout, so we all think of turnout as being a risk factor, and actually the evidence of the effect of pasture turnout is conflicting and a bit limited, but generally accepted, and I do recommend that a lack of turnout time is a risk factor for gastric ulceration, and it forms part of my treatment recommendations in terms of increasing turnout time. So looking at the grading of equine squamous gastric disease. So there are a variety of different grading scales that have been published over the years for equine gastric ulcers. However, this is the grading scale proposed by the Equine Gastric Ulcer Council in their 1999 meeting, and it was adapted and adopted at that point, and has generally recommended to still use this, and it's the most widely used of the grading system. And it's basically a 0 to 4 scale, looking at the degree of epithelial damage, so the degree of ulceration, erosion, hyperkeratosis, and also taking into account the number and size of lesions. So you go from grade 1, which is where the mucosa is intact, but there are areas of hyperkeratosis. Grade 2, where you might have only small focal ulcers or some multifocal but shallow lesions. Moving on to grade 3 and 4, where you have more extensive lesions. For grade 3, they might still be superficial, and grade 4, these are going to be the extensive lesions with deep ulceration. And then moving on to our equine glandular gastric disease. So unfortunately, our understanding of this condition is much less complete than for equine squamous gastric disease. Our understanding of the pathophysiology is limited, but factors that have been proposed to contribute include breakdown of mucosal defences, bacterial colonisation, stress and inflammation. So we know that the glandular mucosa is continuously exposed to acid, and it normally has a number of protective factors. Therefore, it seems likely that rather than acid exposure being the problem, as it is in equine squamous gastric disease, that it's a breakdown of these protective factors that is the mechanism for development of EGGD. The prevalence of equine glandular gastric disease is very variable, and there's far less studies available for this type of gastric ulcers. In general, as with squamous disease, it does appear to be higher in sport horses and performance horses, in particular warm blood show jumpers. However, unfortunately, most of the studies are looking at individual populations, so it's difficult to compare between groups of horses, as we can do a little bit more with our squamous disease. So some of the studies have looked at Australian racehorses, where the prevalence was between 47 and 65%, sport horses with a prevalence of 64%, and pleasure horses with a prevalence of 54%. And then looking at risk factors, so probably the main risk factor that's been identified in the studies that have been performed so far is an increased frequency of exercise. So there have been studies looking at exercise, and exercising more than 5 to 7 days per week has been shown to be associated with an increased risk of equine glandular gastric disease compared to those horses exercising only 1 to 4 days per week. And then looking at the grading, again, there are several grading systems available. There are 3 main ones. The Equine College of Equine Internal Medicine consensus statement scoring system. So this is a qualitative scoring system that basically evaluates the lesion severity, appearance and distribution. So this is most useful for classifying the glandular ulceration based on the appearance, so for example hemorrhagic or fibrinous suppurative. There's also the original Equine Gastric Ulcer Council EGUS scoring system, so this is the same as we use for equine squamous gastric disease. However, it's just been adapted to be more applicable to glandular gastric ulcers, so it includes the presence or absence of hyperemia and the number or severity of lesions as well. Because of the variety of scoring systems available, again, this does make comparison between studies difficult, makes it more difficult to interpret the literature that is available. So I tend to use Table 2, so the Equine Gastric Ulcer Council scoring system. However, the main thing is probably to pick a gastric ulcer scoring system for EGGD and use that one for your own cases and stick to it to allow you to make your own comparisons. So numerous clinical signs have been attributed to equine gastric ulcer syndrome. However, there's little evidence to show a direct association between particular clinical signs and the presence or absence of lesions on gastroscopy. And horses with equine gastric ulcer syndrome do not always show clinical signs, and if they do, they don't always correlate with the severity of lesions. In general, particularly in adult horses, these clinical signs can be fairly non-specific, and also between equine squamous gastric disease and equine glandular gastric disease, there's not necessarily a clear definition between the two types of ulcers and the clinical signs they cause. Therefore, I've included them all together here. So typically clinical signs might include horses being fussy eaters or having a poor appetite, having a poor body condition or actually losing weight, behavioural changes, which might include signs of aggression such as biting, or things like nervousness, signs of colic, which might be acute or recurrent mild episodes of colic, stereotypical behaviours including cribbing, and poor performance, which is a fairly kind of non-specific catch-all description of the clinical signs that these horses might do. And there are minimal studies investigating the link between signs of poor performance and equine gastric ulcer syndrome, which is likely due to the many confounding factors that make interpretation of these clinical signs difficult. And then looking at foals, ulcers are most common in older foals, sort of at or after weaning, where that's obviously a very stressful time for them, but ulceration has been reported in neonatal foals as young as 24 hours old. While clinical signs of ulceration in foals can also be fairly non-specific, there are a few more kind of specific clinical signs that we might see, including tallyism or bruxism. So the classic sign of foals standing there grinding their teeth can be a clear indicator that that foal may have gastric ulceration. They'll often have poor body condition or weight loss, and we'll probably see this clinical sign more commonly in foals than we do in adult horses with gastric ulcers. They might show signs of colic. And then probably an important thing to remember about foals with gastric ulceration in comparison to adults is that they are more likely to develop severe disease compared to adult horses. So this includes the perforation of full thickness gastric ulcers, which results in gastric rupture, or they can develop strictures of the pylorus and duodenum as a result of gastric ulceration, which results in gastric outflow obstruction. The gold standard for diagnosing gastric ulceration is gastroscopic examination, so this is required for a definitive diagnosis. Gastroscopy allows the vet to determine the severity and location of ulceration, and this allows them to be able to direct treatment effectively. Unfortunately, blood work such as haematology or biochemistry is not useful, and likewise there's no association with fecal albumin or hemoglobin, despite there being fecal tests available for that. Empiric treatment can be tried where gastroscopy is not available, and it can be helpful in some cases if the horse has an excellent response to gastric ulcer medication, then this can be a definite indicator that the horse had gastric ulcers. However, it can end up more expensive if you're treating a horse that might not need gastric ulcer treatment. And likewise, if you don't know the type of gastric ulcers you're treating, so equine squamous gastric disease or equine glandular gastric disease, then without gastroscopy, it's impossible to determine whether you're using the right treatment protocol and to assess the response to treatment. So in terms of preparation for gastroscopy, the most important thing is ensuring that the horse is appropriately fasted. So food should be removed ideally 18 hours before the procedure, but a minimum of 12 hours at least. So the night before gastroscopy, it's important to make sure that all food is removed from the stable, and if needed, the horse can also be muzzled if you're worried that it might eat its bedding. And then water should also be removed. Again, that can be removed overnight if there are overnight staff available, but if not, it can be removed first thing in the morning if the procedure is going to be done later in the day. So once the horse has been fasted overnight, it can be brought to the examination room or location where the gastroscopy is going to be performed. So if the horse has not already had a clinical examination, then it's important to do a clinical examination, in particular listening to the heart prior to administering any sedation. In terms of sedation, you want the horse to be sedated enough that it does not object to the gastroscopy procedure, but we don't want to inhibit the swallow reflex too much because that will make passing the gastroscope more difficult. I tend to go for ditomidine and butorphanol, so in the region of 4 milligrams ditomidine, 4 milligrams butorphanol for your average thoroughbred. And then once the horse is sedated, position it with a competent handler and then have an assistant holding the gastroscope. Once in position, the gastroscope can be advanced into the nose up towards the pharynx, so approximately 20 to 30 centimetres in. I'll be looking at the screen to watch where the scope is passing. And then once you reach the pharynx, it's advanced to just dorsal of the rima glottidis, and at this point the assistant should be looking at the horse in the same way that they would if they were passing a nasogastric tube, and then the scope can be advanced down into the esophagus, and if needed you can use some air or water insufflation via the scope to ensure that the esophagus opens up ahead. The scope should pass nice and smoothly down and then it reaches the stomach. So as we enter the stomach, the first thing we can see is looking at the greater curvature of our stomach, so our squamous and glandular mucosa. And as we can see, this horse does have gastric ulceration above its margo plicatus. So initially we can rinse any debris on the stomach using water down the biopsy channel. And then once it's clear, we can then fully evaluate the gastric ulceration. So in this horse, this is probably grade 3 ulceration, squamous ulceration. As you can see, they're fairly extensive but superficial ulceration. And then as we drive around the stomach, we're now looking at the lesser curvature, where again we have squamous ulceration there above the margo plicatus and around the cardia where the gastroscope is entering the stomach. Again, these are slightly smaller regions of ulceration, but still coalescing with even a little bit of deeper ulceration there below the cardia. So once we've evaluated the squamous mucosa, the scope can then be advanced forward to the pyloric region to evaluate the glandular mucosa. So that it first has to be advanced through any fluid in the stomach, and then we should come out here at the pylorus. So as we can see here, the folds of glandular mucosa, and then should open up into the pylorus. So at this region, we do have some linear hyperemia here of the glandular mucosa. And then I'm just about to rinse one area that looks like a hemorrhagic or suppurative lesion there focally at approximately 8 o'clock around the pylorus. And as we see now, we'll try to rinse it off with fluid via the biopsy channel. And this does not rinse away, so it's a true glandular gastric ulcer at this region. And then again, we can fully evaluate this region, rinse as needed to be able to assess whether any other gastric ulcerations might be hidden under food material. And once we've evaluated, we can then back the scope up out of the pyloric region through the fluid in the stomach to again be able to evaluate our dorsal fundus and the squamous mucosa there. And then we can do another evaluation of our squamous and glandular mucosa over the greater and lesser curvature of the stomach. And then prior to removing the gastroscope, we want to make sure that we remove any air that we've inflated the stomach with at the start of the procedure. Otherwise the horse will be at risk of colic post the procedure, so using suction we can remove any air left over. Following the procedure, the horse will remain sedated for a period of time, so it's important to make sure that they don't have access to any food to ensure that they don't choke if they try to eat while sedated. So we'll just place the horse in a stable and leave them quietly until they are fully awake, and then they can be reintroduced to food and water, but should have no other complications from the procedure. So we've gastroscoped the horse and not found gastric ulcers. What should we do next? So really the next steps are going to be determined by the presenting clinical signs, and primarily whether these are gastrointestinal or behavioural. And this is going to determine whether or not we go forward into perhaps a poor performance investigation if our clinical signs were behavioural, or further investigation of the gastrointestinal tract. So in a horse presenting with primarily signs of poor performance or potentially bad behaviour under saddle, where gastroscopy is negative, then a complete poor performance workup is warranted. This will likely start with an orthopaedic examination, so a lameness evaluation and axial skeletal examination, and then further diagnostics can be based on these results. So this might include a more complete lameness examination with nerve and joint blocks as needed, followed by diagnostic imaging, or it may require going straight to some more advanced diagnostic imaging, so something like nuclear scintigraphy, if the source of the poor performance is not obvious. Whereas if we have clinical signs that prompted gastroscopy that are primarily related to the gastrointestinal tract, such as weight loss or colic, then our further investigation can focus on the GI tract. So further diagnostic tests that we might want to do include abdominal ultrasonography, glucose absorption tests, biopsies from the rectum or duodenum, or peritoneal fluid analysis. Now, if you have a horse that does have ulcers, so a positive diagnosis on gastroscopy, then primarily we're going to be looking at the medical management of gastric ulceration. So the first line of this is going to be our pharmaceutical treatment, and this can also include our pharmaceutical prevention, and then our nutritional and environmental management changes to help manage and prevent the diagnosis of gastric ulceration in the future. So the first drug we think of for gastric ulcers is omeprazole, and this is our first line of treatment for both ESGD and EGGD. So omeprazole is a proton pump inhibitor, and it impairs the pump that secretes hydrochloric acid. So there's several oral formulations available. However, the most important thing when looking for an omeprazole product is that omeprazole does require buffering or protection to prevent degradation in the stomach. So this comes in the form of either buffered paste formulations or enteric coated granules are also available. And there's no significant difference in the bioavailability or gastroscopic outcome between these two products. There's also an off-license injectable formulation of omeprazole. This is administered at 4 mg per kg intramuscularly every 5 to 7 days versus oral omeprazole, which is administered at 4 mg per kg orally once a day. And the injectable formulation can have its place in the management of certain cases. However, the main thing to remember is it is off license and therefore the cascade should be followed when prescribing this medication. Other options for pharmaceutical treatment include the H2 receptor antagonists such as ranitidine, which block the histamine receptors on parietal cells, but these have been shown to be inferior to omeprazole in various studies. Sucralfate, which is a mucosal protectant. This binds to exposed subepithelium and stimulates mucus and bicarbonate production, and we'll talk a little bit more about sucralfate when we discuss the specific treatment for equine glandular gastric ulceration. Misoprostol, so this is a synthetic prostaglandin E analogue, which we know increases blood flow and increases mucus and bicarbonate production and decreases acid production. And then esomeprazole. So this is a second generation proton pump inhibitor, and it's an S isomer of omeprazole. So there's limited evidence for the use of esomeprazole. However, the research so far shows that it may be beneficial on horses on a concentrate diet compared to omeprazole. Now looking specifically at the treatment for equine squamous gastric disease. So as discussed, omeprazole is going to be our first line of treatment, and this is at a dose of 4 mg per kg orally once daily, generally for 28 days as our initial course of treatment, so 4 weeks. The enteric coated granules can also be used, and these are given at a slightly lower dose rate of 1 mg per kg orally once daily. Now, the vast majority of squamous lesions will heal within 28 days, and in fact, most of this healing does occur within the first 3 weeks of treatment with omeprazole. The other part of treatment of ESGD is going to be our management changes. So as we discussed earlier when we talked about risk factors, continuous access to pasture or good quality forage such as free choice hay is going to be the important part of this. and then minimising the amount of concentrate or starch feed that the horse receives. And then prior to exercise, feeding a chaff meal will help to form that fibre mat in the stomach to prevent acid splashing. So it's always recommended to feed prior to exercise to try and reduce some of the acid splashing as the horse exercises. And then for the more long-term management of these cases, from a prevention perspective, omeprazole can be used at 1 mg per kg, so a quarter dose, orally once daily. And this can either be long-term or, probably more applicably, can be used at times of stress, so in the days running up to a management change, competition or transport, to try and reduce the pH of the stomach and reduce the risk of gastric ulcer reoccurrence. And then looking at equine glandular gastric ulceration. Now we know that there is reduced healing of glandular disease using only omeprazole, so only 25% healing with 4 to 5 weeks of omeprazole versus 63% healing if using omeprazole combined with sucralfate. And this again comes down to potentially the role of the failed mucosal defences, requiring the addition of a mucosal protectant for that glandular mucosa. So for this reason, we'll use omeprazole at the same dose rate of 4 mg per kg orally once daily. However, for an extended course, so generally 6 to 8 weeks initial course of treatment. And then sucralfate can be added in at a dose of 12 mg per kg orally twice daily, again for 6 to 8 weeks. And these medications should be administered approximately an hour apart to ensure the most effective action of both of them. And again, management changes. While our understanding of equine glandular gastric disease is not as clear, we know that exercise at an increased frequency increases our risk, so we recommend decreasing the frequency and duration of exercise to less than 5 times per week. I do also recommend following the similar dietary and management changes as for squamous gastric disease, so allowing continuous access to pasture or free choice hay, just to try and reduce any risk of ongoing ulcers and to try and prevent them in the future. Now, it's important to use a good treatment technique when administering these medications, particularly omeprazole. So omeprazole should be administered on an empty stomach to allow complete absorption. And then, as I mentioned earlier, we should allow ideally an hour between administering omeprazole and sucralfate so that the omeprazole can be fully absorbed prior to the administration of sucralfate. The drug can be administered simply into the side of the mouth, similar to administering a worm or an anthelmintic treatment. If the horse is not good for medicating, then it's important to have good restraint, using a head collar so that you've got good hold of the horse, and then simply insert into the side of the mouth and administer the medication. It can be set to the appropriate dose. For most horses, this will be a full tube, but in a smaller horse or a horse on a lower dose, then the tube can be set to only administer the desired dose. Then for ongoing monitoring of gastric ulceration, so in horses that are on treatment, in an ideal world, it's important to repeat gastroscopy before stopping treatment. This will allow us to know whether the gastric ulceration has healed completely or whether there may still be ongoing gastric ulceration, in which case decisions may need to be made as to whether a different treatment protocol is required. So for equine squamous gastric disease, a treatment course of 4 weeks is adequate before repeat gastroscopy. But as discussed earlier, equine glandular gastric disease often requires a longer term treatment. Therefore, it's recommended to complete a course of 6 to 8 weeks of treatment before repeating gastroscopy. The other part of monitoring is to monitor clinical signs. Now, in horses where clinical signs were perhaps non-specific or very minimal, then this can be difficult. However, in many horses where there were specific clinical signs observed, including aggressive behaviour such as biting when the horse is being girthed, then owners can often quite quickly notice a positive response to treatment. Thank you for completing this module. I hope you found it useful. There's now 10 multiple choice questions for you to complete.